Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Lisa Stromquist and your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. And since we're live, I just want to remind everyone you have the opportunity to type questions into the question box at any time. So we're going to check for questions throughout the session, so please don't feel like you need to wait until the end of the presentation before you put them in. Also, we encourage you to share your thoughts on Twitter and be sure to tag us at ChildHealthCan. And today I would also ask you to use the hashtags Vote for Every Child, Stand Up for Kids, and Invest in Kids. Before we get to today's session, I also want to mention Children's Healthcare Canada's annual conference in Ottawa, December 8th to 10th this year. Registration is open and we have a great lineup of keynote and concurrent sessions. So today's webinar is part of our Election 2019 Getting Kids Back on the Radar series. So far in this series, we've heard from our partners at the Canadian Pediatric Society, UNICEF Canada, and Children First Canada, and got a sense of the breadth of child health issues that might be relevant in the context of a federal election. We've done a deeper dive into some of the areas that Children's Healthcare Canada and our members are specifically interested in, talking about issues related to appropriate regulations for pediatric medications and formulations, national pharmacare, Indigenous health, pursuing reconciliation through Jordan's Principle, and data sovereignty. But today we're talking about child and youth mental health, a topic important to many in healthcare, social services, and really every aspect of life. So we're going to hear about mental health services and system issues, learn about validated interventions, programs, and systems for both prevention and treatment here in Canada and internationally. We're going to consider actions to be taken that would improve research and evaluation of system readiness, collaboration between service providers, system and service co-design with families and clients, performance measurement, accountability, and transparency. And together, we can think about a call to action for new and dedicated children's mental health funding, coupled with a comprehensive long-term plan. With us today to talk about this, we have Dr. Charlotte Waddell, a child and adolescent psychiatrist, professor and director of the Children's Health Policy Center in the Faculty of Health Sciences at Simon Fraser University. We also welcome Dr. Peter Zetmari, chief of Child and Youth Mental Health Collaborative Hospital for Sick Children, the Centre for Addiction and Mental Health, and University of Toronto. Also Director, Kundal Centre for Child and Youth Depression, Centre for Addiction and Mental Health. And we have Christina Bartha, the Executive Director of the Brain and Mental Health Program at Sick Kids and the Sick Kids Centre for Community Mental Health. So you can see their bios on the Knowledge Exchange Network. So to get us started today, I'm going to hand the mic over to Dr. Charlotte Waddell.
Good morning, good afternoon, and thank you so much. Can everyone see the slides okay? Wonderful. So I'm introducing the title on behalf of all three presenters, and today we want to talk with you about Children's Mental Health Time for Change Canada. And just before I begin, I'd like to invite everyone to join me in celebrating the First Peoples whose traditional territories we're privileged to be gathering on today. So, why do we need change in children's mental health? The first big reason is that the needs are very, very high. Recent data from Canada and elsewhere show that 20%, or 1 in 5, or 1 million Canadian children aged 4 to 17 years struggle with mental disorders at any given time. That includes struggling with symptoms, it includes struggling with functioning, it includes not being able to, for example, do as well at school or even participate at all sometimes. And there's a long list of mental disorders that start in childhood and that affect young people. Anxiety, attention deficit hyperactivity disorder, substance misuse, behavior disorders, depression, autism, and eating, bipolar, and psychotic disorders. Yet we know from recent Canadian data as well that only between a quarter and a third of those children who do have full-blown disorders are actually being reached by current mental health care services. So an enormous gap, and a gap that we would not expect to tolerate for child physical health problems, where, for example, for childhood diabetes or cancer, we would expect to treat 100% of those children. And partially because of the lack of treatment services, disorders often persist into adulthood and then cause ongoing burdens, symptoms and impairment and distress for the individuals, and young people cannot meet their full potential when that's occurring. The second reason why we need to change is that the costs are very high as well. Childhood mental disorders are now the leading cause of global disability for kids. We hear a lot about childhood obesity, we hear a lot about asthma. Children's mental disorders are causing a greater burden. But the financial costs are also high, and looking at mental disorders writ large, these are estimated to cost Canadians approximately $60 billion annually. Yet when we look at what happens when you try to prevent or even treat, for example, just one case, I'm looking here at the example of conduct disorder, preventing just one child from developing this disorder could save over the lifetime $4 to $6 million, so more than enough to pay for prevention and treatment programs. Now, is it a shortage of money? We often hear, hey, budgets are tight, we can't afford this. I would argue with that, and these figures come from the Canadian Institute for Health Information, which tracks annual Canadian health spending, and we spent, last year, $254 billion, about close to $7,000 per person. It's higher than many other wealthy countries, just to put that in context. About 37% of provincial territorial budgets are going towards health, so we're spending at very high levels. 94% goes towards health care itself, so hospitals, medications, physicians. Only about 6% goes towards public health, including prevention. If we looked at the figures for children's mental health, which these reports do not break out, the figures would be much, much lower. And finally, nearly half of that health spending in our country goes towards older Canadians. So the issue of spending more in the earlier years is another opportunity. So high needs, high costs, but what can we do? This table shows that list of childhood mental disorders that I mentioned earlier, just with some prevalence figures, but really what I want you to notice is the top 5 that are outlined in red, those disorders are all preventable. So for example, anxiety disorders, cognitive behavioral therapy programs in schools and communities, you can reduce the incidence of anxiety disorders, and that's the most common group of disorders. There's evidence for all the others as well. For example, conduct disorder, how do you prevent that? You offer very early parenting programs, things like nurse-family partnership, going into the homes with high-risk families. So we know how to prevent about half of the disorders affecting young people. How about treatment? The news is even better. We can treat, we know about effective treatments for literally all of the disorders affecting young people. Often that's psychosocial treatments, again, cognitive behavioral therapy for things like anxiety and depression, parenting programs, and community-based programs for behavior and substance use. School-based programs can even be used. So we know how to treat all of these. So there's lots that we can do, but how to pull all that together really involves making comprehensive mental health plans for children. Those plans need to involve providing effective treatment for 100% of children with disorders, offering effective prevention programs to everybody that could benefit, and coordinating leadership at the national and provincial territorial levels, like we do for child physical health issues. So, basically federal leaders, federal elected leaders can step in, as can federal civil servants, for example, looking at incentives for provinces and territories. And that goes to the next point, that we badly need to increase the children's mental health budgets. And those are run at the provincial territorial level with support from the federal government. But beyond the increases, if we're going to reach 100% of the children, we also need to earmark or dedicate the funding, draw a circle around it so that funds, for example, coming from the federal government go into provincial or territorial coffers, but do go towards child mental health. But another example, and I'm saying some of these examples mindful of our federal election going on, a supporter like the federal government can also ask for accountability, ask provinces and territories to measure outcomes in children's mental health, and to actually demonstrate improvement. So this election is a huge opportunity. And overall, taking a public health approach is probably the best way to really tackle the shortfalls that we currently have, promote healthy development for all kids, prevent disorders for kids at risk, treat all kids with disorders with those effective treatments, and track our outcomes. If we did all this, we would, down the road, even within about 5 years, could potentially have a very different international profile. For example, UNICEF has called us out. Oh, Canada, our kids deserve better. We can do that. We can make that a goal. Thank you so much.
Thank you, Dr. Waddell. I'm just going to pass the mic now over to Dr. Peter Zatmary.
Hi, everybody. Great to be on this webinar, and great that there's so much interest and excitement about child and youth mental health. I'm going to talk about key international innovations to build a...
Peter?
Yes?
So we're just not seeing your screen just yet, so.
Okay.
There we go, perfect, thank you.
Sorry. Too many buttons to press. So I'm going to talk about key international innovations that I think might help us build a rational mental health system for children and youth. Okay. All right. Just having trouble moving the slide. Try this one. Okay, I'm having trouble moving the slides. Let me go do this. Oh, that doesn't work either.
Peter, it may be that the GoToWebinar panel is brought forward on your screen. So if you click directly on the slide or right onto PowerPoint, it'll sort of bring that ahead, and that should.
There we go. Can you see the slides now?
Yeah, perfect, thank you.
Okay. Sorry about that. So I don't think it takes a lot of convincing to suggest that the mental health system for children and youth in Canada is a mess, and Charlotte has alluded to that in the UNICEF report. As she mentioned, there is this new data from the Ontario Child Health Study that was published recently, showing that only roughly a third of kids with a mental health disorder access services. Even if they do access services, they often endure long wait lists prior to receiving treatment. And once they're in treatment, often evidence-based interventions are not consistently implemented. One of the reasons I think for that is that the best evidence is hard, in fact, to access. So the first innovation I want to talk about is from the United Kingdom, and it focuses on the use of clinical practice guidelines. So clinical practice guidelines are a way of finding the best evidence. And here is a well-known evidence-based healthcare pyramid that rests on many individual primary studies that are synthesized into systematic reviews and meta-analyses. And then those are synthesized into clinical practice guidelines. And there are many clinical practice guidelines for diabetes, cardiovascular disease, stroke, et cetera, et cetera. What makes clinical practice guidelines sort of the apex of the evidence pyramid is that they represent not only a synthesis of the best research evidence, but invariably there are going to be evidence gaps, and those are filled in by stakeholder input, the values and preferences of patients and citizens, as well as professional expertise, the wisdom of clinical judgment. It's important to note, however, that not all clinical practice guidelines are equal. And if we look specifically at children's mental health, there are a lot of clinical practice guidelines out there, and it's hard to know which to choose. So we've done a systematic review of all published clinical practice guidelines on a number of different mental health disorders in kids, including depression, anxiety, suicidal behavior, disruptive behavior disorders. And we've compared the clinical practice guidelines for a particular disorder on the basis of the rigor of the literature review, the extent of bias, the extent of editorial independence, and the involvement of youth and families in the formulation of those clinical practice guidelines. And it was very striking to us that the best clinical practice guidelines were consistently produced by NICE from the UK, the National Institute of Health and Clinical Excellence. And I'll just note here that these NICE guidelines are funded by the UK government. Many other lower quality clinical practice guidelines are funded by special groups or professional societies, etc. The problem with the NICE guidelines is that they're very much oriented for a UK audience, and they're extremely long. So the guidelines for depression, for example, are roughly 166 pages. What we've done is to take these NICE guidelines and we've sort of simplified them and stripped away the UK jargon to make them relevant for a Canadian context. And here I've just got an example of one of the NICE guidelines for depression and the psychosocial assessment. Really, you can see that what we've done is distill this down into a treatment algorithm that conceptualizes, captures the elements of the clinical practice guideline. If you're interested in learning more about the guidelines, I'd be very happy to chat with you and help implement even these guidelines in a clinical setting. The second innovation I wanted to talk about comes from the USA, and it's about collaborative care models. So collaborative care models really involve three essential components: a primary care doctor, a case manager with training in mental health, and a mental health specialist like a psychiatrist or a psychologist. And the key ingredient here is that the case manager has regular contact with the patient, organizes their care together as part of a treatment plan with the primary care doctor and the mental health specialist. The case manager or case navigator in some jurisdictions can offer help and advice to the family about the mental health problem, but also plays an important role facilitating access to other services. And I just note here at the bottom, there's an excellent meta-analysis by Asarno, recently published, who did a meta-analysis of 5 different randomized control trials on these collaborative care models. and the combined effect size for this model of delivering service was quite substantial, 0.63. The University of Washington has really taken an international lead in the development of collaborative care mental health models, and they've listed, you can go to their website, which I've put at the top here, they've listed 5 essential ingredients for the development and the implementation of collaborative care models, including shared care plans, making sure that you're responsible for a population of patients who are regularly screened. So screening is an important part of this model. Measurement-based care, so measuring outcomes, and making sure that evidence-based interventions are provided, making sure that the care is accountable. I've added a 6th item, which is not part of the University of Washington summary, but this is the notion of stepped care models, which are an important part of collaborative care, which refer to the judicious allotment of resources matched to the needs of the client. So not everybody gets a standard intervention. The intervention is tailored to their needs. And there's an excellent website, which is Canadian based, that talks in detail about stepped care models in child and youth mental health. The third innovation this time from Australia, are integrated service hubs. So integrated service hubs are really sort of walk-ins. It's a community store. It's a one-stop shop for mental health services. And a really important aspect is that it's designed by youth along with mental health practitioners. And these integrated services, these one-stop shop services, provide a range of services from, say, brief solution-focused therapy to psychiatric consultation. And I put here a reference to a review by Sedapani, who outlines sort of the common ingredients of different models of these integrated service hubs around the world. In Australia, the most well-known, they're called Headspace, but they've also been implemented in New Zealand, in the United Kingdom, and in Ireland as well. In Canada, we do have some of these stepped care models. One is Youth Can Impact in Ontario, Foundry in BC, Open Minds Access has these hubs in several different provinces. The only randomized control trial internationally will be the Youth Can Impact trial, which hasn't completed yet, but hopefully you'll have some really interesting and important outcome data. So thank you very much. Those are my 3 important service innovations.
Thanks so much, Peter. And now we'll just pass it on to Chris.
Okay, thanks very much, Peter. And can I just confirm, Lisa, that you can see my slides?
Yes, we can see your slides. Thank you.
Okay, great. Okay, so I'm going to be approaching the discussion from the perspective that I hold, which is one of being a person who's operationally responsible for running and delivering child and youth mental health services out of a hospital and at 2 community sites here in Toronto. And I'm going to apologize in advance to our national audience. I know I'm going to sound very Toronto-centric, but I'm hoping that some of my comments will resonate with my colleagues across the country, and I'm certainly interested in their perspective. It's been interesting for me as I've followed the federal election. I've heard very little about health and even less, if anything, about child and youth mental health. So as I prepared for today, I thought about what would I do, how would I handle a conversation with the federal candidates right now as it pertains to child and youth mental health and our opportunity to elevate the importance of this issue in 2019 and beyond. And the way I think about it is from the perspective of, as a service provider, what do we know? What do we already know? What are we doing? What would we do in the future? And what could we say at this time if we had an audience with any of the federal candidates? And I'm going to build from the really excellent presentations from Charlotte and Peter. Because from my own perspective, I think that despite the fact that we may still have many opportunities for further research, evaluation, and building out services, I think we have a good foundation from which to grow, but we have an absolute burning platform for action. The need for spread and scale of some of the current models that we have evidence to support is profound across the country. But what I would say from a more optimistic perspective is that we do have excellent evidence and excellent models, both within Canada and around the world, that really can inform service design and provision going forward. And I would say cross-sectorally, but particularly in the sector that delivers child and youth mental health services, I think leadership is very ready to respond and collaborate and build and grow systems of care across the country. And that's been a big conversation in Ontario, where there is really collective agreement that waiting to move on child and youth mental health and to close the gap between need and service availability is something that we simply cannot continue to wait to do. And so the motivation to move forward, I think, is very, very high. So I'm going to focus my comments on what I think are 6 directions for success that can help us across the country build integrated, comprehensive systems of care for children, youth, and families. And I think you'll see that much of what I'm going to say ties back to the earlier comments of Charlotte and Peter. So the first thing is we absolutely do have very good models for early intervention prevention, called different things in different places, sometimes called infant mental health as well, working with high-risk parents and families to deliver programs that support parenting skills, positive infant-parent relationships, really optimizing and supporting kids to be ready for school. And here at Sick Kids, in the community, at our community mental health sites, we have 3 services that we offer that collectively probably offer, I would say, over 10,000 clinical contacts a year to high-risk parents and their children, working collaboratively with public health, with our Healthy Babies, Healthy Children program, but really from a group-based paradigm offering intervention that is very effective and done in collaboration with other community providers. And this is a service that, or these are sets of services I think that we need to grow and scale and preserve what we already have within the system. And that's been a priority for us here at Sick Kids. Across the community, both our own community sites and our colleagues who offer community-based resources across the province, as Peter said, there's been a very, very positive growth in the Youth Can model or walk-in clinics. These are one-stop shops, as Peter said, for youth to come in and access services. Youth who are identified as high risk are then referred on to more intensive services. But the model has really been very successful at providing immediate service to a very large number of youth who might otherwise not have been able to access any care. We also have brief intervention, family counseling models, excellent youth outreach models that are often done in collaboration with our education partners, embedded directly in high schools and junior highs. And then, of course, within our service agencies, longer-term individual and family therapies and day treatment models being offered for the higher need kids and youth. But for these intensive services in the community, we often have very long waiting lists, and we're not able to respond in a timely and effective manner. And that is one of our pressure points in the community that I think we have the opportunity to develop. And we already have the models available, we just need to grow capacity. And much as we're building our capacity to meet the needs of kids and youth in the community, it doesn't obviate the need for more acute services that are hospital-based. So specialized day hospital, inpatient and intensive therapies for complex clients and patients remains a high need area, both in Ontario and I'm sure across the country. And one of the areas where we often will have seasonal fluctuations that lead to very high numbers of kids coming into hospital, and real challenges in trying to effectively meet their needs and transition them back to community for effective follow-up. I think mental health is probably one of the areas of healthcare that has the highest degree of collaboration between mental health providers and our partners across education, child welfare, and primary care. And I think that collaborative capacity and that collaborative commitment within mental health really positions us very well for the future in building integrated care models and more seamless treatment planning for kids and youth. But we need to do it more, and we struggle at times to do it efficiently. I would say this is one of our strengths and one of the things that we need to build on for the future, and a real opportunity to provide more effective care to kids and youth. And the point number 5 really focuses on another really significant challenge for us in child and youth mental health, which is capacity building and training. If we look at the amount of new information, and Peter referenced it in his comments, evidence-based care requires ongoing investment in training, education, capacity building for clinicians, primary care practitioners, our colleagues in justice, youth justice. We have to become increasingly attentive to specialized issues across marginalized and specialized and vulnerable populations. And all of this requires ongoing training and investment for our clinicians and our providers, often an area where we don't have sufficient resources and capacity. But I do think that in child and youth mental health, there is tremendous motivation to be able to embed this in our clinical service delivery models and to become much more proficient in doing this. And I think that electronic platforms provide us with a lot of opportunity going forward to be able to do this more effectively. And because I'm an administrator, my last point around organizational accountability really comes from the fact that I think in an era where resources are scarce, we have an ongoing obligation as service providers to focus on enduring process improvement and standardization within our service delivery models and the way, frankly, we run our agencies. That's been a big part of the work that I've been doing at Sick Kids, both in the hospital, in the community. And it really speaks to the issue of access, trying to redesign our service models and our workflows such that we're able to better leverage our resources in order to free up more capacity to deliver clinical care and reduce wait times, which is often a very significant barrier for our kids, youth, and families who are looking for services across our service continuum. So I think we're in a position now where we absolutely we have a critical need for investment. And I would position these 5 items on this list, services and resources, as where there is an opportunity to suggest that additional resources would make a very big difference in being able to close the gap between demand and need. So I've run through these, which is prevention and early intervention, community-based care, acute crises and acute services and crisis support 24/7 available, supporting cross-sectoral collaboration and co-design of services with our clients and our families, something that needs to be resourced in order to be effectively embedded in our systems of care. And finally, capacity building and training with particular emphasis as we go forward on cultural competence, trauma-informed care, and concurrent disorders, which includes both addictions and kids and youth with concurrent medical conditions. And the last thing I would add is the emerging importance of supporting our youth as they transition to the adult services, another area where specialized training can be very, very effective. I think Charlotte mentioned the importance of measurement and data, and I couldn't agree more. I think we have a need to focus on quality. And the way to do that is through investment in the capacity to have technology in our service provider environments, to collect data, and to be able to analyze data and work with it from a research perspective. And in the child and youth mental health sector, this is often an area that receives very little attention and very little infrastructure investment. But what it would do going forward, collectively is foster a national opportunity of sharing best practices, approaches, and outcomes here in Canada, which could be very helpful. So what I would say, I would borrow heavily from the National Health Service, which has published some great stuff. I've included a couple of links to mental health strategies, both from the UK and Scotland. In 2016, the National Health Service published the commitment in child and youth mental health to deliver the right care at the right time with the right quality. And I felt that those sets of statements really spoke to what we're trying to do here in Ontario and across the country, and our imperative as we go forward, and the key things we really need to emphasize during this federal election, where we have the opportunity to elevate the interests of children and youth who are dealing with mental health challenges. And I am going to stop there. So thank you.
Thank you, Chris and Peter and Charlotte. That was a lot of information. We've learned about some of the data, about some of the effective interventions, about some of the programs, and about the capacity and the desire for clinicians and all of those people in the front lines and all of the leaders who really want to make a difference. So we've heard a lot today. I'm going to encourage everybody to post their questions. I'm just wondering myself, so Chris, you were talking about, the national strategy and the strategies that you've shared from other jurisdictions. So do the three of you, do you believe that we have enough information? Do we have enough of the resources? Do we have enough to actually work together to build that national strategy? Do we have enough expertise here in our country and enough resources and enough will to build that national strategy?
Well, I'll start off. It's Chris speaking. I think we have the knowledge, we have the motivation. I don't think we have the resources to do this in a fulsome way, and I think that's one of our challenges going forward, is to really illustrate what the gap is in resources for child and youth mental health, especially in comparison to what other parts of the healthcare system receive relative to the need. I think that's probably our biggest challenge going forward.
Yeah. And maybe I'll just add a small note that the two of the three countries that I mentioned, the UK and Australia, have been able to influence the mental health system for children and youth because the health system is accountable to the federal government, not to the individual states or to individual sort of jurisdictions. It's the federal government that runs mental health in the UK and in Australia. And that makes it difficult for us because, of course, health is a provincial jurisdiction. So trying to get the federal government and the provinces together is an ongoing challenge.
And Charlotte speaking, I'll just build on those excellent points. And just, I would say that we do have the resources. That slide on health spending in Canada and where most of it is going, I hope is illustrative that as a high-income country, we should spend a lot on health, among other things, but we need to shift some of that spending towards children's mental health and towards young people more generally. I think the question of is there a will, I hope any election is an opportunity for really putting things on the policy radar, so to speak, on the policy agenda. And I really appreciate the opportunity to be on the call with a number of people today that may be in positions to take leadership to try to really push children's mental health forward. And I think, despite what you just said, Peter, yes, indeed, it's provinces and territories that have jurisdiction over health and public health and also social programs, some of which may overlap with children's mental health. But the federal government can do quite a bit to encourage. There can be active forms of leadership, and there are examples. For instance, This is going back a long ways to the year 2000, but the federal government crafted an early child development accord, asked all provinces and territories to sign on, gave substantive funding, but made provinces accountable for spending that money on early child development, and they had to report on what they spent and some reporting on outcomes. A similar initiative by the federal government and by senior civil servants at that level, elected leaders at that level. If we could do that for early child development, we could do that for children's mental health. And I will just comment, those early child development investments have endured. They've gone through, liberal and conservative governments. The money is still flowing to the provinces. There's been a build out of early child development capacity that's been really robust. And we could do the same. We could do the same for children's mental health.
Comments from all of you. So we have a few other questions coming in. Should hubs in high schools be encouraged or strengthened, or should they be outside of the education system?
So I think definitely schools do have a very important role to play in the mental health system, and I'd love them to play a greater role, both as a way of screening kids that are at high risk, as a way of providing programs to every kid in the school, and so that universal way of providing information. But also we know that we know from the evidence that there are some really good mental health programs that can be delivered within schools that can make a difference. Substance use, depression, anxiety, suicide prevention, another great example of how wide scale programs directed at that condition can make a big difference delivered within the school system.
Thank you. So to you, Charlotte, perhaps you know the answer to this. So what were the strategies used to obtain federal interest and funding in the early childhood development?
A few things, and they're all things that I think we could replicate and should get going on for children's mental health. One of the issues was amassing the research evidence. So in the case of early child development, it involved looking at neuroscience and other evidence on brain development, and it involved also linking that to intervention evidence. So that was the first step, and in my view, always should be, to make sure that any policy or practice recommendations anyone ever makes are informed by robust research evidence showing effectiveness in children. But then what happened after that was researchers and advocates got together, and some very, very powerful coalitions formed. And these were people that were eager and willing and very capable of kind of opening all doors, including the Prime Minister's door, and doing that across the country at the level of premiers and cabinets, and doing that tirelessly over, to my knowledge, it took about 5 or 10 years of that kind of coalition and staunch advocacy. And then, a Liberal government, as it happened at the time, was open to hearing that message, and provincial governments were willing to accept the funds for this cause and accept the strings that were attached to that federal funding. We're in the place of having ample research evidence in children's mental health. We know a lot about the epidemiology, or things like the prevalence and the impact in Canada. We know a lot about how disorders play out, and it goes very badly if we don't intervene. And there are many, many prevention programs now with randomized controlled trial evidence. Likewise, many, many treatments. As I said in that one slide, we can show we know how to treat all of the childhood mental disorders. So I think, it's time to really look at a national coalition on the scale that they did for early child development, and that would include people like Peter and myself as researchers. It would include certainly Children's Healthcare Canada, and I'd be interested in hearing from others who would like to get going on this.
That's great. Thank you so much. We have some questions now about data, actually, and about measurement. So how do you measure success of the programs and models? Do you use an indicator? If so, what kind of data works best? And in an ideal world, what kind of indicator would you use to measure positive outcomes for children and families accessing the services? So basically, how do we get the data to strengthen this cause and the argument for this national strategy and the benefits?
So maybe I'll just start. That's a great question and complex. There's a lot of interest in the concept of value-based healthcare, which is really achieving an outcome at a specified cost. So we want to measure outcomes and we want to balance it against costs, but sometimes we need to put more money in order to achieve a good outcome. So measuring outcomes is a complicated area. I would say that what we should be doing, and one of the national initiatives that I think is worthwhile, is that we should all be using common outcome measures in our services, whether they're community mental health services or hospital mental health services. And choosing what those outcome measures should be and what the targets are, what the key performance indicators are, should be an exercise that involves a wide group of stakeholders, not only service providers, but children, youth, and their parents as well. And then implementing these are called core outcome sets, which have been developed in many physical disorders, but not yet in child and youth mental health disorders, I think would go a long way to improve, bringing us together nationally and having some consensus about what good outcomes might look like.
We have a question, I think maybe for Chris or for Charlotte. Can you discuss the link between infant and early mental health to the prevention of some mental disorders in later childhood?
It's Charlotte speaking. Maybe I'll just jump in with one quick response and then hand it over to you, Chris. The link in my mind really starts before children are born. So in the prenatal period when the conditions are created for wellness. So for example, is the family prepared to support the child really well? Are they strengthened in their parenting capacity? Are they able to maintain their own health? So for example, preventing things like substance exposure in utero. So that's some of the things. I mean, some of the very early programs like Nurse Family Partnership, they start in early pregnancy to address those things. And then, in the first couple of years of life, those kinds of intensive parenting supports for those who are at risk, those supports continue and can really set children up to have a very good experience in the first 2 years of life. For example, much more positive home environments, freedom from things like child injuries or child maltreatment, and thereby, entering the toddler years in as basically as well as possible and able to learn, able to thrive. And then, some of the other kinds of prevention programs can pick up from then on in the preschool years, things like the peri-preschool enriched daycare setting, very much probably the most intensive early childhood program, really supports parents and starts really supporting the kids with learning goals and just also supporting their mental health. You do all of those things by the time children turn 5 or 6 and enter the school system. If there have been early disadvantages, those have been remediated or could be to some extent, so kids start school in a more equal place. And then other prevention programs can carry on from there. Things like, for a little bit, children who are a bit older, anxiety prevention programs in schools. That can work in the elementary and middle school years. Substance use prevention programs for kids who are maybe in the middle school years. So you can have a continuum starting in early pregnancy, going through to the end of high school, really. So the link is between early pregnancy, infancy, toddlerhood, and then the school years. But over to you, Chris.
Thanks, Charlotte. I think what I would add to what Charlotte has said is in my earlier comments, one of the programs that we run in Toronto, which is called the Building Brighter Futures program, is actually part of a program started by the Public Health Agency of Canada 25 years ago, and it's been running ever since, which is for babies and children under the age of 4 and their caregivers to build the very skills that Charlotte outlined in those young children in those early years in order to ensure that they develop social, emotional, and cognitive skills, and their parents are supported, and they are optimally ready for school when they enter JK or kindergarten. And this program that we run here in Toronto, which is run all over the country as well, is really focused on some of our highest risk families that are identified to us, with the goal of early intervention as a strategy to prevent some of the risk factors that these kids and their families have as a result of a myriad of circumstances. And I would completely agree with Charlotte that the program, first of all, it touches the lives of about 800 families a year, just at our setting alone, and has been one of the best examples of sustaining a high impact program in child mental health that I've seen in many years of delivering services. And I think these are the kinds of things that we need to continue to build out and sustain and retain in an environment of constrained resources.
Thank you both so much. So I have a question here from Crystal. Says the implementation of a one-stop shop style of integrated hub are less feasible in rural areas, including Indigenous communities and other communities that are more geographically spread out, so making it difficult for youth to access them. What do you suggest as solutions to these challenges? Is the collaborative care model the best approach?
Yeah, I think each community needs to think about what's the architecture of service delivery that makes the most sense for them. And here I'd emphasize again the possibilities of telemental health, of internet-based interventions. There's now accumulating evidence that some of the interventions that you can get on the internet, if they're with a coach, can actually be very effective and can be delivered at long distance. Psychiatric consultations, mental health consultations in general can be delivered at long distance. So some of the barriers that we've experienced in delivering services to remote areas, I think, has been decreased with putting together the collaborative care model and accessing services via virtual platforms.
And can I add that I think for providers who are working to deliver services to some of those more remote communities, I think electronic solutions are increasingly being made available for the professional development and support of providers who need to deliver care in that kind of a context as well. And I think there's a lot of promising models in that area that could be built and scaled out over the next few years.
Well, thank you so much. I just want to go back to a comment I think that Charlotte made about a national coalition and who all should be involved in that. So Children's Healthcare Canada, certainly we've been working to bring together some of the players and some of the stakeholders. So we have our Child and Youth Mental Health Practice Network, and we're just sort of getting up and running and building out our plans for the next few years. I can't say that we can develop a whole national strategy on on child and youth mental health, but I can say that we can, we'll have some great minds there to maybe help put some thoughts down on that. Who else do we think that we would need at that table? Who would be part of a coalition to bring this together, to make this happen?
So I would say that's a fantastic way to start things off. I would say there are people at the provincial territorial level who have taken significant leadership in children's mental health, and I would reach out, for example, the directors of children's mental health services. There's a person in British Columbia, for example, that runs the province-wide community-based children's mental health service. And through your own organization, you would already be covering, some of the more hospital-based services, which are included in what you do. So I would reach out to the leads for children's mental health across the country. It looks a little different in every province and territory, but there are nevertheless people whose job it is to take the lead, and I think would be very responsive and very pleased to hear about such a coalition. I would also reach out to parent and youth groups. Again, these are a bit different in each province and territory too, but I know in BC, for example, we've had active engagement for a long time with parent advocacy groups that have been very, very helpful, and parents have been fierce advocates for children's mental health needs. The example of autism, for instance, shows that parents with their advocacy, they've been able to really increase the resources going to the care for kids with that mental health problem. We could do it for others.
That's great. Thank you. Any other thoughts from Chris and Peter?
I think that I would agree with everything that Charlotte has said, and I would add that mental health is a very cross-sectoral service delivery model. So we have mental health leads in education, child welfare, and really every aspect of child health service delivery. And I would be reaching out to the leads in other sectors to be part of, one voice, one message to increase the focus on child and youth mental health.
Great, thank you. I think that we're coming up to the end of our time here. Are there any last thoughts from any of our panelists that you might like to share with the community?
Just my last thought is I see from my computer screen there are 79 people on the call, and I would invite all 79 of you to join in this effort.
I agree.
Thank you, Charlotte. That's great. Thank you.
All right then. Well, thank you, all three of you, for your thoughts and your wisdom and your calls to action. And I think that we have a lot to think about after this call and maybe some work to do. So appreciate all of that. So just in closing, I just want to tell everybody that we do our webinars every Wednesday at 11 a.m. Eastern Time. And just like today, it's always great if you can watch live, as the questions and comments really enrich the discussion. If you can't watch live, the recordings are always made available after the fact on our Knowledge Exchange network. So this is the last in our Election 2019 series, but I invite you to visit our Election 2019 page on the Children's Healthcare Canada website, and you'll find information and tools to help you get involved, as well as the recordings of this webinar series. So tune in next week to Spark Live as we welcome Dr. Yasser El-Sayed and Dr. Deepak Lewis from the Winnipeg Children's Hospital, and they'll discuss 3 interrelated programs in a session: a new paradigm of physiologic-based critical care. So I invite you to go to our election website, and you can see it up on the screen. You'll have information and resources, how to get involved, our social media toolkit, and again, the links to the recordings of this webinar series. And you can also sign up for Children's Healthcare Canada Spark newsletter and stay up to date on all of our activities and events. So thanks everybody, and hopefully we'll see some of you back here next week. Bye-bye.